Good morning, everybody. I hope you're all keeping well. My name is Caroline Wadege. I'm your moderator for the day. And I'd like to thank every last one of us for creating time to be here today. We don't take it for granted. So, karibuni sana. We are going to discuss ear diseases and hearing problems in children with autism. I know it's going to be a very informative session. Feel free to ask questions. For some of us, it's the first time to interact with Gifted Gems, and we'd like to tell you just a little bit about us. We are an organization that provides civic education on autism to caregivers of children with autism. We also provide psychosocial support and also equip caregivers with basic skills in this journey of autism. We advocate for early intervention, early identification, diagnosis, and intervention. And that is part of the reason why we do the webinars amongst the other programs that we do. So today, we are very excited to have with us Dr. Lillian Mokoh. She will be introducing herself. And even as before I introduce her or call her to speak and take it away, I would like to hear from you. What are your expectations for the day? What would you want, to achieve or to see achieved at the end of this webinar? Let's take about 5 minutes and let's hear from you. You can chat or you can just raise your hand or unmute yourself and speak. Anyone with an expectation? Thank you, Catherine. Mechanisms of hearing loss in autism. That is well noted. Thank you for that. Yes, Claudius, go ahead, please.
Good morning. So I'm expecting to learn more about ear diseases and hearing problems in children with autism, and maybe some of the interventions and interdisciplinary collaboration in terms of management for these diseases. Thanks.
Okay. Thank you. Thank you for that. Speech therapy in Coast Province, that's another expectation. Thank you, Brighton, for that. We appreciate all the input. Hello, how to manage hyper children. Okay. Thank you for that, Alex. We appreciate. So without much further ado, I want to bring in Dr. Lillian. Dr. Lillian, as you have seen in the poster, I'm just looking at it right now. Dr. Lillian is an ENT surgeon and also an otology fellow, University of Cape Town. I know she'll be telling us more on ontology. Maybe for some of us, it's the first time we are hearing the word otology, and we are really looking forward to learning more from Dr. Lillian. So Dr. Lillian, I welcome you. Please introduce yourself and take it away from there. Karibu sana.
Thank you so much, Catherine. And good morning to everyone. As Catherine has rightfully introduced me, I am Dr. Lillian Mokoh, and I am an ENT surgeon based at Kenyatta University, teaching referral and research hospital, that is KUTRRH. And I'm currently an otology fellow. Otology is the study of ear disease. So I'm basically an ear disease student at the University of Cape Town. But I am predominantly an ENT surgeon at KUTRRH. So I hope to have specialized by the time I'm done here on ear surgery and ear diseases. So I will be giving you the presentation today. I'll be teaching you about ear diseases. and we will be specifically focusing on children with autism. I have some slides that I would like to show you so that you can follow my conversation. Sometimes ear disease can be a little bit complex. I will also try to be as slow as possible, and I hope that I will meet most, if not all, of your expectations. Some of the expectations might be a bit hard for me to meet, especially based on my scope, but I will try my best and answer as many as possible. So when we talk about ear diseases, and let me just stop my video for purposes of focusing on the PowerPoint. So when we talk about ear diseases, we mainly want to look at ear diseases in children with autism. And for children with autism, we want to first understand, for people who may not be having the knowledge, I'd like to start by trying to explain what autism is. And autism is a spectrum disorder. A spectrum to mean, just like when we talk about a color spectrum, you have various colors that follow in a spectrum. So autism is a neurodevelopmental disorder that is characterized by mainly issues with a deficit in social development, in language development, and in their behavioral development. Neurodevelopmental, that means development of the brain, and it falls in the broader category of conditions that we nowadays call neurodiverse conditions. Basically, neurodiversity is a way of describing people who have special and different ways in which they experience and they interact with the world around us through their senses. And we know all these senses and how we interact with the world, primarily that is something that is driven by the brain. So when we call it neurodiverse, it means that these are people whose brains work a little bit differently, or these are children whose brains work a little bit differently than the brains of normal people. Normal people, not really normal, but what we call neurotypical people. That is how a majority of the people and what we have known to be, or what we have labeled to be normal, perceive to be how we should be functioning. So these are people who are just like me and you, but then they perceive, or their brains perceive, the environment and react to the environment differently. Now, autism is quite a prevalent disease. One, because there are a lot of speculations, there are a lot of changes that are happening in the world, there's climate change, and there are a lot of conditions that are coming up. And at the same time, it is also quite common because more and more of us are knowledgeable. And so we are gaining more information. And so we are diagnosing more and more children who probably in the past days could not have been diagnosed. And so according to WHO, the prevalence is 1 in every 100 children. So if you have a group of 100 children, at least one will have a form of autism. This is not reflective 100% of our country, because we need to do our own studies and we need to go deeper, a little bit deeper, so that we can understand what our prevalence is. But generally, in the world, we talk about 1 in every 100 children having autism. Now, hearing loss is, we said that neurodiverse people experience the world differently. Now, we experience the world through our senses, and we have 7 senses, but I'm going to talk about the major senses. The major senses being the sense of eyesight, the sense of hearing, the sense of balance and proprioception. We have the sense of touch, and we have the sense of taste, the sense of smell, and the sense of having an intuition. Intuition meaning that sixth sense that all of us have inside our body that warns us about danger and all those things. So those are the 7 senses. And hearing loss is one of the major senses. That is a sense that is primarily found, or it is the organ of that sense is the ear. And the ear takes responsibility for 2 senses. that is both hearing and balance. And so when we talk about hearing loss, we're talking about somebody with a deficit or a reduction in their sense of hearing. And this can range from mild to profound. So depending on where you fall in the deficit, it can also be reversible or permanent based on what could have caused the loss to occur. When we talk about prevalence, again, due to the similar issues as autism, we still don't have our own prevalence in the country. But generally in the world, we talk about every 3 in 1,000 children have a form of hearing loss. But this has been shown to progressively increase to around 7 in every 1,000 children. When you look at children at around 5 to 7 years, these are the preschool age children. And we are going to see why, in particular, these children, we have an increase in the prevalence, possibly because of the fact that preschool children have a lot of ear conditions or recurrent ear diseases, infections mainly, that make them make the prevalence go a little bit higher. Now, and when you look at the causes of hearing loss, the causes of hearing loss are quite diverse, and they cut across all life stages, to mean that at any given point in your life, at any given day, you can develop a hearing loss. And hearing, when we look at hearing loss, they can be genetic causes, they can be genetic, can be due to intrauterine infections, can be due to birth-related complications, like if the mother has prolonged labor and the child has birth asphyxia, or if the children develop jaundice, if the children are admitted in NICU or ICU. We have childhood infections like meningitis, acute infections such as acute ear diseases that keep occurring. They can cause ear infections. Ototoxic medication. So most of the times the medication that we are given in hospital, in some people can cause a hearing loss. Commonly some medications such as some antibiotics, chemotherapy medications, some of the medications used to treat common diseases, including hypertension, sometimes can cause you to have hearing loss. We have exposure to noise, especially if you are exposed to very loud sounds, or if you're exposed to continuous noise for long periods of time, then you're at risk of developing a hearing loss. We have some diseases that have currently been linked with hearing loss, including lifestyle diseases such as diabetes, thyroid diseases, and diseases like hypertension. These are diseases that affect the end organs. End organs being the organs that are mainly at the peripheries of our bodies, like our eyes, our kidneys. That is, in terms of the blood supply, that is the last place that the blood supply to that organ goes to. So the ear is not any different from other end organ diseases. And so any disease that affects an end organ then can also affect ear disease. And finally, we have the most common cause of hearing loss, which is old age. So as we grow older, our level of eyesight, our level of activity, and the same thing, our level of hearing also comes down. So when we look at causes of autism, same thing, but autism, mainly we have 4 main things. We have genetic causes, we have the paternal, what we call paternal age, and maternal age in some cases. Then we have some intrauterine drug exposures and environmental risks. What I want you to get from these two is the fact that if you look at the causes, they are all different causes, but they somehow are similar. So it is sometimes you can have a child who has no risk factor has autism, but has a risk factor of hearing loss and can develop hearing loss, and vice versa. You can get a child who has a hearing loss, maybe a genetic hearing loss, and at the same time has a genetic error that causes them to have autism. And so you cannot really isolate the two. Now, for you to be diagnosed to have autism, you need to have difficulties forming and understanding relationships. using verbal communication and sharing interest or engaging with other people. And then on top of that, you can have repetitive movements, difficulties with change, or you can be highly restricted or fixated on how to do things. And these children also have hyperactivity or hypoactivity to things in their environment. So, and we said that we perceive our environment through our brain and this is mediated by our senses. So this hypersensitivity or hyperreactivity or hypo, meaning lower, can be through our sense of sound, sense of touch, sense of sight, and sense of proprioception. So I've listed how to diagnose autism because autism, most of the times in terms of diagnosis and recognition, is very similar to how hearing loss also can present, especially in very young children. Most of the times when you have a small child who is autistic or a small child who has a hearing loss, most of them are probably going to behave the same way. And we will think we have normal children because they have, or rather we have a child who has no problem because they do not have any physical, anything that shows they have a physical disability. And then at 1 year is when everybody will start asking, how comes my child is not talking? How comes my child is not communicating? My child is not playing. And at that point is when we start wondering, is it that my child cannot hear or is it that my child is autistic? And so in terms of age of presentation, most of us, because we are not looking for these disorders, we find that both autism and hearing loss are diagnosed at 1 year, or the age of presentation is above 1 year. That's when we start suspecting. In terms of presentation, most of them present with speech delay. So most of these children, because the child with autism has communication difficulties, they are not able to talk. So we find that most of them present with speech delay. At the same time, the child with hearing loss has, in order for you to develop language, you need to be able to hear. So these children also present with speech delay because they're not able to respond to their environment. So both categories have speech or language delay. They have no response. The children who are autistic have difficulties with change and they have difficulties in engaging with others. So sometimes when you have a child who is autistic, then you will easily find that your child can present with not responding or not turning to their name. And this is something that is quite common. A child who is 9 months old, if you call their name, they can easily turn and look at you or look at the person who calls their name. And so this could be a sign of autism. At the same child, a child who is not able to hear, especially the ones who are profoundly deaf, then they also cannot turn to the names when they are called. And so both of them would present in the same way. And then they both use gestures to communicate. The autistic child is not able to form language, so they point at things. When they want something, they either pull you and take you there. And that is the same way that a child with a hearing loss would communicate, to using gestures and pointing at things. And so when you look at both categories, that is how similar they are. And that is why we are having this webinar, to see how to differentiate the two. Of note is that they also have their own differences, but then we will look at the differences a little bit later when we're looking at the presentation. Let's first try and understand about the ear and how we hear. So the ear is basically an organ that is quite mysterious because most of the ear is hidden inside our heads or inside our skulls. And what we see is just the outer part of the ear. And so the ear is divided into an outer ear, a middle ear, and an inner ear. The outer ear is mainly just like a funnel that leads all the way to the eardrum. And the work of the outer ear is to collect sound, just like a satellite. So the outer ear is a satellite that collects the sound and directs it to the eardrum. Once that sound goes to the middle ear, it is amplified and it is transmitted to the inner part of the ear, which has two main parts. The first part is the part that is concerned with balance. This thing things that look like roller coasters here. And then the second part that looks like a coiling snake is the one that is involved for hearing. So the main organ of hearing is inside, and it is connected to the brain through nerves, which take the message out into the brains. And so if you have a child who is autistic, or if you have any child can develop complications or diseases in the outer ear, can have problems in the middle ear, and they can also have problems in the outer ear. When you have problems in the inner ear, when you have problems in the outer ear, we call that, in the middle ear, we call that conductive hearing loss. And most of the times, because this is the part of the ear that is easily accessible, it is treated by using interventions such as medication, and the hearing loss it causes is most of the times reversible, either by medication or by use of surgical interventions. However, if anybody has a problem in the inner ear or in the nerves, then we call it sensorineural hearing loss. And most of the times, it is very difficult to reverse this type of hearing loss or this type of hearing problem. Now, I want to take you step by step to look at what common things or what things can be found in children with autism that can present in these parts. And so we want to look at the outer ear conditions. Outer ear mainly starts from the outer part of the ear, what we call the earlobe, and it goes all the way to the eardrum. So there's an ear canal. Some of the common conditions that you find children with autism is that they can, most of the times, these children have repetitive behavior that sometimes can be self-harming. For example, when they are frustrated, our children find themselves hitting. Either they can hit themselves against something or they can hit themselves. And the outer part of the ear is quite exposed. And so sometimes it can be injured or traumatized. And so some of these children often get injuries, or they can get injuries to the outer part of the ear. The funny thing is that the outer part of the ear is quite sensitive, and so the injuries are very, very painful. And at the same time, the healing, because of it is mainly made up of cartilage, the healing does not heal very well as compared to normal soft tissue. And so they can have an injury that ends up healing with deformities that make the ear look different from how it was looking before. And sometimes they develop what we call a cauliflower ear. The second thing is that these children are neurodiverse, and some of them have they have neurodevelopmental issues. And one of the common things we see in children with neurodevelopmental issues, especially the ones who have a form of mental deprivation or mental retardation, is that they have a tendency, or they have a habit of putting objects or things into their ears. This is quite common, and I'm sure some of us have experienced this, where your child is so much attracted to putting a particular thing inside their ear. It could be a bead, it could be a pencil, it could be a crayon. And this is quite common when they go to school. And so it is important for us to keep looking into the ear canal of our children who are autistic, and just lovingly form a habit of, you can even make it a game where you form a habit of peeping to check inside. Sometimes you might find colored things, and then you will be able to see, you will be able to identify that if your child has that tendency or is predisposed to that tendency of putting things inside the ear canal. The danger of this is that this object inside the ear canal can cause damage or injury, either to the eardrum or to the structures inside the eardrum. It can also cause pain or infection in that area, and you'll find that your child will have pus coming out or a bad smell coming out, and it is as a result of a foreign object, depending on what the object could be. The other thing is infections and wax impaction. These are things that can be found in any common person. Any child at any age can develop wax impaction, and they can also develop infections of the outer ear canal. And once they are discovered, then they should be treated. When we're talking about children and ear infection, one of the common conditions is tagging on the ear. Now, our children who are autistic, they have particular mannerisms, and most of the common mannerism is touching their ears. But we have to admit that any mother can be able to identify what is common to their children and what is new. And so if you see your child touching the ear in a different way that is not to their usual mannerism, then you can suspect that probably this child of mine is having a problem with the ear. Of note is that it is not all ear conditions that are very painful. Not all ear infections are present with pain. And so other than acute middle ear infections, most of the other infections are not painful. And so you'll find that the child will tug on the ear, there might be pain, and sometimes there might be a discharge even without pain. And so seeing your child tugging onto the ear, or a child who develops pain or who is crying, especially when touching their ear, should make you suspect that they probably have an ear condition. And most of all these ear diseases, they require you to take your child to an ENT surgeon, because also to examine the ear, or to the pediatrician or to the doctor, because to examine the ear, the doctor has to look inside the ear canal, which is usually another story, especially with our autistic children who are sensitive to touch, especially from strangers. And so it's important, even as you take them to the doctor, you take them with a friendly or with somebody who can be able to calm them down. And that is for the outer ear conditions. Now, the middle ear. The middle ear is this part in between the inner ear and the outer ear. It is the part of the ear that is behind our eardrum. And it is a special part because it is connected to the nose through a tube we call the eustachian tube. More often than not, our children keep getting flus or upper respiratory tract infections, especially when they join school. Now, every time a child gets an upper respiratory tract infection or they get a flu, then they can easily, that infection can or has a possibility of spreading into the ear through the eustachian tube. And this is because the children's tubes are not as mature as the adult's tubes. So they are not, their function is not as an adult function in terms of protecting or opening and closing to prevent communication between the two cavities. And so when they have a flu and the infection spreads up into the middle ear cavity, then the child can get a middle ear infection, which we call acute otitis media. Now, this acute otitis media, how do we know your child, or how do you suspect your child has it? The biggest red flag is a child who is irritable, is crying, has a very high fever, and could be touching on their ear, and could be touching or could be tagging onto their ear. Not all of them will do that, but the presence of a fever, irritable and crying child, every time they're taken to the hospital, then the doctor should make a point of looking into their ear, because especially if they were having a flu or if they're having an active flu, because it could be that the infection has gone to the ear. And once the doctor looks into the ear, that is what they're able to see, and they start the child on antibiotics. Some of these children also present with the pus that could be coming out from the same ear. Now, every time you have an acute ear infection, then the infection usually progresses into forming pus. And that pus can remain in the middle ear cavity and not cause fever, not cause pain, not cause any infection. However, it is going to cause a dysfunction in the function of the middle ear. We say the middle ear is the amplifier. And so if these small bones are surrounded by pus, then they become a little bit stiff and they're unable to do their work, which is to amplify sound. And so these children develop a hearing loss. This is very, very confusing to a child, especially a child with autism, because this is a child who is already not able to express themselves socially. They're not able to communicate very well. And so the fact that they develop a hearing loss could make could confuse them, and they could make their symptoms or their presentation to be a little bit rough. So you'll find that this child is a child who will be a little bit more confused in how the sounds are being perceived. Some of the children they actually, if they were responding in some way to sounds, then they actually totally stop responding to sounds. Some of them, I know it is common for children with autism to pick up words and then forget. If they had formed some language or some words, some of them drop them, or all of a sudden they are not able to keep up with the language or their vocabularies. And so it is important to also have your child have their ears checked, especially after an ear infection, as a follow-up to see. And when this is present, then even in normal children, it causes them to experience or to have a speech delay. And so when we diagnose children with this condition as ENT surgeons, I'm sure most of you have gone to the doctor and you've heard the doctor talking about putting some tubes. So those are the tubes we put, and the tubes usually are put on the eardrum, and the tubes are mainly work by draining the fluid from the middle ear cavity. And once the fluid is drained, then the child is able to hear. When you have the fluid, you hear how, if you want to try and experience what those children experience, you can go into a swimming pool and just sit or go under the water, then ask somebody to talk to you. That is how the children feel. And so when the fluid is drained, then the hearing goes back to normal. And it is one of the commonest causes of treatable or reversible hearing loss in children. Again, our children are not an exception. Whether or not they have autism, all children are at risk to developing this. And this is the main reason as to why the prevalence of hearing loss increases as the children are growing, to reach a maximum of 7 per 1,000 when they are in the preschool age. Now, the last entity is chronic otitis media, which is mainly when these children have repeated infections and the eardrum finally develops a permanent perforation. This permanent perforation leads to permanent discharge. And this discharge can be on and off. When the child has a flu, their ears leak. When the child is fine, they're fine. Sometimes when they go for swimming and water goes into their ear, their ears have pus that is leaking. And chronic ear infections should be treated by sealing the hole on the eardrum. And when they are sick, the children should be given some ear drops. So again, the biggest challenge here for the doctor is examining the child of the autistic child. And I cannot overemphasize that when you're coming or when you're planning to visit your ENT with a child who is autistic, it is very important for you to carry or to come with help. You can come with people, especially people who are able to calm the child down, and people who are able to help the child cooperate. I'm sure the children have favorites, or they have people who they are able to cooperate best with. Even if it is the house girl, then it is important for you to come with them, so that because it requires a team effort to convince the child to allow the doctor to look into the ear. And the basis of diagnosis of all this condition is looking inside the ear. Now I'll go to the last part, which is the inner ear. The inner ear is now the one that is the organ of hearing, and its work, I said, is maintaining balance and maintaining or perceiving sound. That is, its work is to hear and to coordinate balance. Of importance is that it is very rare for children to develop balance disorders from ear diseases or ear infections. However, some children can have that, and that mainly usually manifests as lack of balance or lack of coordination. It is not a common thing, so it is not something that I really want to concentrate on. I'll concentrate on things that are more common, which are things that have to do with the nerves and how the children who are autistic hear. So with this, I will look at the physiology of hearing. How do we develop language? And basically, the organ, once sound has gone through the outer ear, it has gone through the middle ear, it has been amplified, it is taken to the inner part of the ear. In the inner part of the ear, this yellow represents the sound. The sound goes through different places or different pathways in our brain, where it undergoes coding, it undergoes processing, and it undergoes different adjustments that help us, one, learn the language. It helps us appreciate the sound. Two, it helps us know what the sound or understand the meaning of that sound. At the same time, it helps us develop either an appropriate response to that sound so that we can have the message being sent back in order for you to respond, and sometimes you storing that message in your brain. And so this happens through nerves. And now the nerve pathways are like wire cables or the internet cables that are underground. And these nerves or these nerve pathways, they conduct and they have different stops at different areas of the brain, and they communicate between one side and the other side. And so for us at our level to understand is that the main, when we are talking about children with autism, these children can present with, most of them, they present with deficiencies or different ways of how their nerves perceive, how their nerves decode, or how their nerves process different sensory inputs. And so if we were to focus on the hearing input only, a child who is autistic has a different way of processing any sound stimuli based on the particular pathology that they could be having. But one of the things that has been proven currently in research when looking at autistic children, and why almost all of them are perceived to have a problem in language development, is the fact that there are two areas of the brain. There are two areas of the brain that are involved in understanding and processing in terms of decoding of language or decoding of sounds to form language. And people who are autistic predominantly have been found to have a problem or a deficit in how they decode the language, such that sometimes, and in terms of decoding, it is to mean that sometimes they have coding deficiencies. So the signal could come, and once the signal comes in, you find that they are not able to put it together in a constructive way. And this has mainly been shown to be predominant mainly in the language. But when it comes to music, it is quite good. And that is why you find that music therapy is one of the most common therapies that is used to soothe. Or you will see, I will explain to you that you can use music to help these children to calm down, because their coding for music or their coding for instruments is easier and it's better than their coding for language. As to the details of that, I think it is quite scientific and quite complex. And so I will just try and see. So when you have sound coming into your ears, I will just try and explain that when you have sound coming into the ear, the sound goes up the brain, and the brain does several things. One, the brain helps to directionalize the sound. So it helps you understand that this sound is coming from left or from from right, so that you can be able to know where the sound is coming from. Based on how loud it is or how soft it is. The second thing is that sound is usually available in different frequencies. And so, given the different tones and the different pitches of sound, then the body is able to process. And that is what helps you understand that it is a word that has been spoken, or it is a scream, or it is a bang, or it is an instrument that has fallen down, or it is a dog that is barking, based on the different pitches and how those things sound. But how we learn that that is a dog that was barking, that was my name that was called, that the same sound has to communicate with the different areas of the brain that deal with memory storage. So that if every time people look at you, they call your name. For example, my name is Lillian. Every time people look at me, they call me Lillian, Lillian. That is how children get to know that Lillian is my name. So that by the time they are 7 months old, when you say Lillian, they all turn towards where the sound is coming from, and they are able to look who is calling Lillian. And with time, because it is a sound that is constant, it is mom's sound, then the memory again stores this sound, and the brain is able to associate and understand that was mom calling Lillian. And so they look and they smile. If it is a new sound based on the pitch, then the children are able to understand that that was a different sound. So maybe it is the new teacher after they have gone to preschool, but they are calling Lillian, and that could be me. And so they are able to turn their gaze towards that person, and they will see who the person is. So basically, we have different areas. And if it is language formation, then with time, we learn. We learn that when people say hi, you have to say hi back. Same functions. You have to have that memory working. And at the same time, you need to have feedback so that when the brain processes and understands that you just were given or you were told hi, the brain is able to process and say, oh, the response to hi is, hi, how are you? And that is from teaching, and teaching occurs recurrently, and it is facilitated by memory, and at the same time also coordinated using the other senses. So using the sense of sight, by looking at people, you're able to associate them with the language, you're able to associate them with the gestures, you're able to associate them with what they're saying or what sounds they are producing. And then using things like smell, touch, all the senses, that is how the brain works, by integrating all that to help us to develop language and not just appreciate sounds as we hear them. So when we talk about hearing loss in children with autism, we know that all children who have a diagnosis of autism have a form of problem in terms of coding language. Their centers or their networks for coding language are depressed compared to other neurotypical children. And so most of them, in as much as they have hearing, most of them do not necessarily have hearing problems, but what they have is processing disorders. So as a baseline, all children with autism have a processing disorder. But remember, we said autism is a spectrum. So depending on where you are on the spectrum, you could be having a mild processing disorder, or you could be having a severe processing disorder. You could be having, and we will look at these processing disorders. Generally, we say that up to 7% of children with autism have a mild to moderate hearing loss, and 3% have profound. This probably could be due to the fact that both autism and hearing loss have genetic problems, or they have risk factors that overlap, or it could be just a coincidental finding. 40% of the children who are also deaf have other neurodevelopmental conditions, of which autism is one of them. But generally, when you look at deaf children and ask yourself how many of these deaf children have autism, the prevalence rates have been shown to be just 1%. So that is not very different from the normal population. Another thing is that 18% of children with autism seems to have hyperacusis. Hyperacusis is sensitivity to sound, and that is why a child who holds onto their ears or a child who blocks their ears is commonly labeled as a child who is autistic, because most children, up to 18% of children who are autistic are sensitive to sound. And we have seen earlier in these slides that one of the ways that you can diagnose autism in a person is being sensitive to one of the senses. So being hypersensitive in the responses to one of their senses. So whether hearing, eyes, or touch. And so it is not unusual that we have 18% of these children with autism having hyperacusis. Now, I'm sure I have given a lot of information, but to just slow down, I'm sure you want to ask yourself, so how do you differentiate between this hearing loss and autism, or how do I guess that my child has both? And the most important things that we look at is in the behavior. If you have a small child, a small baby, and one has autism and one has hearing loss, some of the things that we want to look at is things like eye contact, social skills, and then the language and the interaction with the environment. So behavioral assessment is what will mainly let you suspect that the child has autism more than has autism and not hearing loss. And from what I have explained, we have seen that children with autism having a language processing or decoding problem, they also have a problem with attention. Most of them are not able to make eye contact. Most of them do not interact very well with the environment, especially if it is not interesting for them. And attention is something that is required for you to learn language. If you don't pay attention to where the sound is coming from, if you don't pay attention to what people are doing or how people respond, how people communicate, then you might not be able to learn how to respond appropriately or learn how to have the appropriate language cues for social interaction. So this is another reason as to why this is another problem that children with autism have. Then they also have a problem, some of them on the spectrum have a problem retaining information. So it's like information gets in through one ear and it goes out through the other ear. They do not process that information, they do not retain that information. And then they have a deficit, they have a problem with interacting with the environment. So again, they do not integrate information from activities. They do not look at people, so they're not able to form language because they cannot understand that when your is shouted, your mom's face is angry, and so you're able to know that it shouts, you're able to know, hey, today mom is angry. So that is something that children with autism are not able to process, and it's mainly because of the fact that they are not, their deficiencies or the characteristics or the neurodiverse characteristics that are associated with autism do not allow them to form proper language and to form proper cues. So they are at disadvantage, and this is why most of the children who have autism have delayed speech development and they have delayed language development. Now, when we look at their sensory sensitivity, most of them present with hyperacusis. This is a very common finding, and it is a sign of auditory sensitivity. Auditory sensitivity means that sound could be very loud for them, or the sounds could be very irritative to them. When the sound is irritative, or it makes them feel angry, or it agitates them, that is called misophonia. When normal sound, like normal conversational sound, is too much for them, that is called hyperacusis. When hyperacusis, that is very sensitive to loud or even normal sounds. And then some of them have hypoacusis, where normal sound is presented to them, but their body perceives or their brains perceive that sound to be of lower volume. So the problem is not that their ears are not working. The problem is that their brains, when processing that sound, processes that sound at a lower volume. The same thing, it's not that these children cannot hear. It is because any sound at a certain level is either perceived to be painful or uncomfortable, and so they cannot handle it. So the brain kind of does not process that sound, and so that child will not hear anything. And so most of them, if you suspect your child or how you suspect your child has any of these sensitivities to sound, they keep blocking their ears. Some of them block their ears and block their eyes, especially when you switch on the TV. And it is because both, they can be sensitive to more than one of the senses. And so it is important for you to understand this and have your child checked. The first thing we do is we confirm if they have a normal hearing. Once we confirm that their hearing or their organ, their inner ear is functioning well, then the problem is probably high above. And there are tests we do, commonly a test called an ABR. The ABR is able to check whether that sound is being processed or is being transferred into the various areas of the brain and whether it is reaching in good time. And with that, we can be able to diagnose if the child has any of these issues. But the most important thing is not diagnosis. The most important thing is how do we help this child cope, adapt, and learn in spite of this problem that they have. And how we help them cope is, remember I said that they have the coding problem is in the language deficiencies, but it is normal for music. So you will find that music therapy is one of the common therapies that can be used, because most of these children, when the sound is too loud, they become irritable, they throw tantrums, some of them they shout, and they are unmanageable to the parent because the parent also now gets angry. It's probably in public and you're not able to help or cope with that child. If you have some headphones at a low volume that is not distractive to the child's ears, if you want to go with your child to the mall and your child is sensitive to sound, then you can have them wear the headphones and play some music. Different children, autistic children, respond differently to the different music, but basics, classical music, just instrumental music at a soft volume is going to distract that child. And you will find that the child will be less anxious, the child will be more calm, and the child will be able to adapt and sit in the environment, especially because we cannot encourage this child to be isolated throughout all their lives. The other strategy is to buy them earplugs. And the earplugs can be of various forms. You can put them in the ear. Some of them can have the earplugs that are put on top of the ear, the ones that look like bunny ears. And those earplugs are quite helpful because what they do is that they filter out the noise and they help the child have an environment where the sounds are not as loud as the outer sounds. And this helps to keep the child calm. It helps the child to concentrate on other things, and it also helps your child to be able to adapt to their different environments. Another thing is environmental modification. What that means is that when you want to interact with this child, especially in family moments or in class, or when you want to teach the child something, do it in an environment that is quiet. If your child is a teenager and they're having a social meeting, instead of telling them to meet their friends or organizing for the meeting to be in a restaurant, which is quite noisy, organize for it to be done in like somewhere where it is quiet, in a garden, so that when they're in a quiet environment, if you're in the house, you don't have to talk to the child and the TV is on and the dog is barking. So make sure that the environment of where that child is modified. Switch off the TV when you now want to have a conversation with the child. turn off background music. If there are people talking and laughing, maybe move to another room or ask them to lower their voices so that your child can be calm enough to enhance communication or to enhance learning. And this applies for classrooms. For children who have been found to have especially hypoacusis, where they perceive the sound to be at a lower volume, then what we use is that we use some things such as FM speakers that are connected via Bluetooth in the classrooms. Those are just assistive devices for these children, and they just help to amplify the sound so that the children can feel better. Not all children who have hypoacusis are candidates of hearing aids. This is because the problem is not the ear. Hearing aids are amplifying devices for the ear. But this is a child who has a normal hearing threshold. So it is important to get a specialist to diagnose your child before you fit your child with hearing aids. It could be the child can hear, but the child just needs to be taught how to process the information, or the environment needs to be modified. And finally, when we are speaking to our children who have sensitivity to sound, we need to slow down. Slow down because the faster you speak to an autistic child, the faster that information, or the easier it is that that information is not being recorded in the brain, so it is not being retained. And so you find yourself, you have to slow down when you're speaking to them. You have to add gestures or add visual cues. So for example, if you're talking about a cup, hold the cup. Do some form of gesturing. If you're talking about, are you angry? Ask them in a slowly way and make a face so that the child can integrate or can maximally benefit from both your visual cues and gestures and from the speech. Slowing down always helps them to process it easier on top of all the other things we've talked about. Now, the next thing is their processing. Again, still related to what I talked about, how we form language and how we form, how we're able to form language and how we're able to respond. It is important to know that a child with autism can have other problems. And the brain, in order for the brain to work, the brain needs to be calm, the brain needs to be at a certain level of ease so that it can integrate all the information that is being collected from all the senses in order for it to make sense of them. And so these are the 5 different types of auditory processing disorders. I will not talk about them, but some of them are as complex as children are not able to understand sound. If you present 2 different sounds or instructions in the 2 different ears, they're not able to integrate and say, my left ear had stand up and my right ear had, after you stand up, pick up the cup. So they are quite complex. And the main thing to learn is that also children with autism could be hyper. And when they are hyper, their brain is also firing at a high rate. So again, they probably need to have assessment by a neurodevelopmental pediatrician who is able to lay out if the child has other issues underlying. Maybe a child is autistic, but now they are a teenager, so on top of autism, they have developed anxiety, and they also have some ADHD, and they have a form of dyslexia. So all these things, when they are diagnosed professionally, then some of them can be treated with medication. For example, if your child is autistic and hyper at the same time, the pediatrician can give them medication to help them calm down. And once they have calmed down, then it can be easy for you to help teach them how to speak or how to understand or how to communicate. And it makes their coping and their understanding easier. So what you need to know is that any child who has processing disorders has difficulty understanding speech. So sometimes you can ask them for, please give me the socks, and instead of socks, they give you the shirt. So they do not decode the information fully, or sometimes they have not formed appropriate memory, or they have not stored enough language. You know, sometimes we fill up the gaps in our heads. You can reach a point where somebody can tell you, give me that thing, and you don't need them to complete the sentence. That is one of the functions of the brain. And so children with autism have this deficit, and so they're not able to keep up. And so it is important when you're speaking to them, use simple language, use visual cues, and be very, very slow, or try and slow down to their own level. Some of them have difficulty responding and following instructions because of the same thing that I said. Sometimes it's because maybe your voice they cannot tolerate it. Maybe you have a very high, high voice, and they're sensitive to high voices or high-pitched voices. And so for them, it is, whenever it becomes uncomfortable, then the brain does not process. And so you can just say, this is a naughty child who only listens to their mother but does not listen to me. It might not be that, it might be that that child just is not able to process your sound. And so with understanding, with love and empathy, then you're able to come down to their level, and you're able to, probably perhaps it's because you speak too fast, you slow down and adapt. They also have worse symptoms, or they behave worse, or they are unable to process sounds when there's a lot of noise, when there's a lot of sensory stimulation, and when they are tired. And so you will notice that your child will make more mistakes in their language, or when they are tired after a long day of playing, or when you take your child to a place where there are lights, at the same time there's noise, then there are so many people, then everybody wants to touch the child. Maybe it is a birthday party that you have organized, and there are different colors around, there are balloons. That is a lot of sensory information for that child to process. And if that child also has auditory processing, then they probably will also shut down. And so it is important for you to understand your child, so that you're able to create healthy environments, or environments that are enabling to your child, or they enable your child to respond appropriately. Now, I've spoken so much about that, but that is how we approach it. In terms of diagnosis, we should be having newborn screening, where all children born are screened for hearing loss. And this would help us perhaps identify the children who are born with a hearing loss earlier. And then if your child has passed the newborn screening, but still is not developing language, we can start suspecting and diagnosing autism earlier. But we also recognize that this does not happen every day, and this does not happen routinely in our country. But if you suspect your child is not able to hear, if you have a very quiet child who does not cry, who is not woken up in noise. I know it is a blessing to the mother when your child is not woken up by noise, but sometimes it could be that that child has a hearing problem. So it is important, if you take them to the hospital, for them to have their ears screened. For those of us who are professionals here, if a child passes a newborn screening using OAE, that is otoacoustic emissions, for children who you expect to have autism, or for children who have risk factors for autism, it does not end there. You have to go ahead and do an ABR. The ABR is the auditory brainstem response, where you send sounds through the ear and you check for the response of the brain, just like depicted on that picture. And the importance of doing the ABR is to check whether the child has processing disorders. Most of these children will pass the OAE. So they will have normal OAEs, which show that they have normal outer ear function, but their ABR will be abnormal. So meaning that their brain is not processing that sound, and that will help early diagnosis and early intervention. Of note is that some of the children with prematurity, with jaundice, and children who have been admitted in neonatal ICUs for some times could also have this same auditory processing disorders, but they reverse within an year. So the best thing is having a professional follow you up. Don't just do one test, jump to the worst conclusion. Be followed up so that you can have the proper diagnosis and be followed up by the right professional who is able to give you all the necessary information and follow up your child. Because you could have a child who is diagnosed to be having a sensory processing disorder, but then in a year's time, it tends to correct itself because the brains of children are very adaptable. The first 5 years to 7 years of life, you can teach a child to adapt. They have a lot of neuroplasticity, so their brains are quite flexible, and so they also tend to repair themselves and they can overcome the problem. There's other many tests like tympanometry and pure tone audiograms, which mainly test for middle ear conditions, especially when the child has fluid in the middle ear. I talked about otoacoustic emissions, which test whether the cochlea is working. The cochlea is the inner part of the ear. We have the auditory brainstem reflexes, and then we have auditory processing tests. These are the different tests that are applied to find out what kind of processing disorder exactly do you have. Is a disorder in processing speech? Is the disorder in decoding speech? Is the disorder in synchronizing speech from both sides of the ear? So it gets more and more complex as your child gets the diagnosis. And then finally, for us at home, it is important to just look at apply behavioral testing and psychometric testing. Look at your child, look at them and try and understand what could be the problem based on what I have presented. Is your child making facial contact? Yes. Is your child very sociable? Yes. Is your child then having speech and language delay? Yes. Then probably the child has more of a hearing problem than autism. Is your child having a combination of these things? If it is yes, then probably that child has autism and maybe could be having an ear problem on top. So behavioral testing and psychometric testing, this is very important to have cooperation and history from parents. So let us be parents who are keen, who are observing our children in terms of what they are doing, how they behave, and how they interact with the environment. Because this is going to help even in the management. Management has to be through a multidisciplinary approach. One, we need to appreciate that there's no one intervention that is tailor-made for one child. There are many different interventions, and given how special the child is in terms of how special their problem is and how severe or how non-severe it is, then we can have interventions that are tailor-made for them. Multidisciplinary approach, because we need different people from different cadres. For you to diagnose autism, you need a pediatrician. You probably need a neurodevelopmental pediatrician to find out if your child is just autistic or they are autistic with other issues such as hyperactivity, ADHD, and other things. So you need to have that person in that group. At the same time, you need an ENT for the ENT and the audiologist to sit down and look and find out, is this child having ear disorders? How severe are the ear disorders? How bad are them, and how can we intervene? You need to have an occupational therapist. In occupational therapy, they do things such as sensory integration. So they help this child to be able to integrate and to adapt to their different senses, and then they're able to teach them how to cope with life, how to cope with the different sensory stimuli in their environments, so that now we can now have people at home and all of us teaching this child how to learn how to communicate appropriately, how to communicate their feelings, how to talk, how to behave in different settings. And so we cannot say that all children who are autistic and they have this problem, they must get hearing aids, they must get cochlear implants. The treatment should be tailor-made according to the goals, how severe or the problems that the child has. It should be based on the needs of that child. If it is a child who is now going to school, if it is an adolescent, probably we need to lean towards a psychologist who takes them through cognitive behavioral therapy to now cope with the different problems that come with growing up, vis-a-vis having play therapy, which is quite common in the younger children who you want to teach to interact with others through play and such things. So tailor-made management approaches for each children. Of notice is that any child who is autistic or who has a hearing problem and they have autism, it is important for them to have the intervention. And the intervention is important because when you intervene with the hearing intervention, you're making life easier for this child. You're filling a gap where there's a deficit. And so depending on how severe it is, the child, if it is a reversible cause of hearing loss, you can give them, they can get ear tubes, and the ear tubes can help them to keep hearing and understanding. That reduces their level of social anxiety. If they cannot hear very well, then you give them hearing aids. If they're able to hear and learn through the hearing aids, it becomes easier for the teachers to teach, it becomes easier for the parent to communicate. And the same thing applies for cochlear implants. Some of them who have processing disorders, depending on which processing disorder they have, then they benefit from cochlear implantation. And so, again, if they get cochlear implantation, it helps them with that particular disorder, and that helps them to cope better. It reduces their anxiety. It removes one problem from the basket of their problems that they could be having, depending on how or where the child is in the spectrum. And that is the end of my presentation. I hope I have not confused you, and instead I have added some knowledge or some understanding. I think I'm open to receive any questions. Thank you.
So there's one here from Daniel. I have a learner who, despite giving him any kind of work, will go back to writing number 12. Another one only find it easy writing number 2. All of them have a good sense of hearing. Is there a trait of repeating things, and how is it connected with autism?
I think that one is part of the repetitive behavior that is found in children who have autism. The repetitive behavior does not necessarily have to be social behavior. It can also be an obsession with a certain number or a certain toy or a certain particular thing or a certain word, even repeating words. And so that is part of their presentation within the spectrum. And it is something that you have to lovingly encourage that child. And you also have to be very, very patient, because it's something you cannot change. It is how their brain processes things. So it has nothing to do with hearing, and it is not a sign of a hearing problem.
Okay, thank you for that. Then there's another one by Nelly. How is oral swimming, not sure if it's swimming or steaming, linked to hearing? My son would shut his ears and begin speaking repetitive words.
Okay, so I think I've explained about the phenomenon of shutting the ears. And sometimes you find that these children shut their ears and have mannerisms that are linked to anxiety. And what happens is that if, for example, that child has what we call misphonia. Misphonia is when you perceive sounds to be harmful, or you don't like the sound, or it's kind of annoying or irritating to you, then one of the way the body copes is by blocking and deflecting, looking for something else that will help you forget that experience. So if a child is hearing sound that is uncomfortable or makes them feel bad at a certain level, they can easily block their ears and start repeating words so that they can distract their brains from perceiving or concentrating on that sound. And so that could be a coping adaptation mechanism. And if you have a child who is like this, again, as I said, there's no one fixed remedy for all children. If you can try giving them the earplugs, if the earplugs help, then that is okay. You can try playing children who have sound sensitivities. So you play some music and you find that the child is able to cope, and then the behavior, they're able to calm down, and then the behavior becomes less and less. So it's about understanding your child and helping them cope with the particular problem.
Okay, thank you. Thank you for that. Where do I get these diagnoses, OAE, ABR, etc.?
So those diagnoses are mainly found in hospitals that have ENT specialists. So I believe you can find it in the major hospitals. I'm sure you can find that in Kenyatta National Hospital. They offer those services. In Kenyatta University Teaching and Referral, that is KUTRRH, we also offer those services. They can also be found in some of the hospitals, county referral hospitals, but also in the major private hospitals, we have these services, hospitals such as Gertrude's Hospital, MP Shah, Aga Khan, most of them have. Mostly, if you go to an ENT surgeon, whether private or public, then they would know the appropriate test for your child, and they would also send you to a center where the test is available. So I think if you start with an ENT surgeon, then they would be able to direct in terms of which test is appropriate for you. Because again, some of these tests are expensive. And so we need to find out what is appropriate to avoid wasting the money, whether or not it is from an insurance cover or from the pocket. And so the best plan is see an ENT surgeon, let them send you to an audiologist, let them send you to do the appropriate tests, and then from there you can have it followed up. Or even a speech therapist, they can be able to pick up what the problem is.
Okay, thank you. Attached to that, to the tests, just a follow-up, there are some tests that we are required as caregivers to for the child to be asleep. And for us caregivers, this is normally sometimes a tall task. So are there any tips, when you're checking on hearing, because the child may have not slept the whole night and will still not sleep when they come for the procedure? Yeah, any tips for a caregiver?
So in this kind of approach, one of the things I would do is one of the common things that we do is goal setting. So in this particular instance, our goal would be to have the child come to the hospital and fall asleep immediately. So we go through the child's typical day. You'll find that these children have a pattern. Maybe this child must sleep in the afternoon and then they wake up and then they take another nap at 10, or maybe they have hourly naps. And the doctor would be able to decide that we will disrupt. If they take maybe 10 naps in a day, we will disrupt and make sure that they get 5 naps. Again, we look at what else does the child do before they sleep. There are children who immediately they eat, they go to the washroom, and then they sleep. So at the same time, we will know that hunger is another thing that probably keeps this child awake. And we will tailor our our approach in this child based on how the child behaves and what induces sleep in the child. Maybe this child must sleep when they are holding their teddy bear, and when the mommy is singing. That means that even if it is daddy bringing the child to hospital, then mommy has to come. Mommy has to come ready to sing, and mommy has to come holding the teddy bear. And sometimes when all those interventions don't work, that is when the healthcare provider now goes to the next step, where we use medication. The risk of using medication is that these children can be given medication that will really, that makes them sleep. So you want to give this child medication in a controlled environment. And so if your child has totally failed to those small adjustment therapies, then we refer you to a bigger hospital where you can have your child put to sleep and the monitoring is done safely. And when the child is ready to wake up, then you're given permission to go home. So it depends on how it presents or how the child presents, and also how urgent and what kind of test we need to do.
Okay, thank you. Thank you for that. It's very common with the caregivers. So I thought I'd bring it out here. There's also a question, and even while I ask if any of our participants has a question, you can raise your hand. You can type it in the chat. We'll be picking it so that we can ask Daktari as she's with us. You spoke about otitis media. Please talk a little bit about it, and especially when it comes to grommets, their maintenance, and the whole process, just to prepare a caregiver, because those are questions that keep coming. I've been told to go for surgery. What do I do, and all that.
So otitis media, one of the biggest complications, or one of the, we call it a sequelae, how it progresses is that it progresses by leaving pus in the ear. And as I explained, when you have pus in the ear, then you're not able to hear well, or you hear as if you're underwater, which means that you barely perceive any sound. And this is it is a disadvantage, because this is a child who will need to have maximum hearing benefit in order to learn, and the child who also needs maximum hearing benefit in order to adapt to the environment. And so when you have a child who has autism and they have fluid in their ears, in a normal, neurotypical children, we sometimes follow them up for 3 months, and then we decide whether or not we are going to put the tubes. Again, in neurotypical children, we assess whether they are going behind in their speech and language development, or if they're able to keep up. Because this fluid clears itself within a period of 3 months, if these children are able to keep up, then we don't put the tubes. However, a child with autism is a different child, depending again on where they are on the spectrum. A period of 3 months is a very confusing period for a child who is autistic, for them to process what is happening to their sense of hearing, which has all of a sudden changed. And that is why you will find that most autistic children, compared to neurotypical children, are often referred for hearing tubes or for ear tubes immediately they are diagnosed with fluid in their ears. Also, because of their language development, we want to maximize. We don't want to waste time. That 3 months is a very long time. They could have lost the little vocabulary that they had gained. And so those are the reasons as to why we tend to prefer to give these children tubes early enough. Now, these tubes are put on the eardrum, and once the ear resolves, or the eustachian tube, the tube that I talked about, once it has started functioning well, the tubes remove themselves. That is, they self-extrude themselves. And so in terms of maintenance, so long as water does not get into that ear, so long as that child does not go for swimming, or, they don't put things in the ear, then the tubes stay there, they remove themselves. In some children, we don't even see or realize, but they take a maximum of 1 year. The point is, they remove themselves when the ear function has gone back to normal. And sometimes on and off, you will find that when the child has tubes, there's pus coming out. Do not panic and say, now you see the child has an infection. No, that means the tube is doing its work. We said that these children get these infections every other time they have a flu. And so if your child gets another flu and they have tubes in their ear, then they can easily, if that infection goes into the ear, they will have pus coming out and the tube is working. All you need to do is go back to your ENT so that they can give you ear drops, so that, or they can treat you appropriately, treat the child appropriately to make sure that the infection does not persist. But that is basically how the tubes work and how they function and what we expect. So we follow up the child and see when the tubes come out and how they are, and if they are getting recurrent infections.
Okay, thank you. Thank you for that, Dr. We have a question here. My son was diagnosed with autism at 2 years. We are turning 10 years. We achieved much, as in we won the battle, but the shutting of the ears with or without noise, still there on and off. Do we need any intervention at this age?
As I said, the interventions go out throughout the life of this child, because in as much as you help your child to cope and adapt, as we grow older, we have different problems that we face in the world. That is a child who is now transitioning to adolescence and childhood and teenagehood, where they will now have other social encounters that will either make their hyper or hypersensitivity become worse. And so for this kind of children, the easiest thing is to sit down and communicate with them, help them be able to appreciate what makes them have this experience. Is it that when they are in a very noisy place, what they find is that the noise becomes irritating? Is it that it is irritating from a particular kind of voice? And this will help you teach your child how to adapt. If it is very noisy places, then you just help them either by having them wear the earphones at a very loud, at a low sound. Again, very loud music playing using the personal listening devices is not very good for the ears. But if you put a comfortable level and they play the music, then they would be able to distract themselves. If, for example, it is when they're in a very noisy environment, then they can have earplugs. And the earplugs can help them adapt when they're going outside, when they're in the field, because they are children who go to school, they go to functions. If it is, and then you teach them to be able to educate their friends so that they don't agree to meet their friends in malls and restaurants, and instead you want them to meet their friends maybe at home or in places that are quiet. So the best thing for this particular child is sit with them, let them communicate what exactly they experience, what is the problem, and then from there, look for strategies that will help them cope or distract them from the problems that they experience or that bring out that experience in them.
Okay, thank you, Dr. for that. Maybe associated with that, there was a question some time back with some caregivers on how frequently we should take our children for hearing tests.
So in the first 5 years of life, or in the first 1 year of life, the child should have quite frequent hearing tests, and it is depending on their risk factors. At least an infant should undergo 2 or 3 hearing tests in the first year of life. After they are cleared, if they have risk factors being if the mother had problems in pregnancy, if this child maybe had a very bad jaundice with high levels of bilirubin, this child was admitted to neonatal ICU, maybe the child had meningitis, then they should have follow-up every year. However, all children every 2 to 3 years up to the age of 7 should have a hearing test. And it is because of these recurrent ear infections. At school, actually, when they join the school age, they should be having frequent hearing screening when they're in school, especially because of the fact that they can develop a loss after getting an ear infection. Some of the genetic causes of hearing loss also take time to show up. And so you find that a child is born with normal hearing, but by the time they are 5, 7 years, that is when the hearing goes away. So in the first 5 years of life, we say at least one hearing test per year is adequate to make sure that child is growing and developing normally. We know this may not be feasible, especially because of costs. And that is why we emphasize on behavioral, knowing your child, knowing their language, being keen on how they speak. If you had a child who was speaking very well and all of a sudden they cannot pronounce words, that is a red flag. If you had a child who was very good, very sharp in school, and then all of a sudden, especially preschool children, all of a sudden they are not performing well, that is a red flag. Maybe they're not performing well because they can't hear the teacher. If you have a child who was obedient, who was responding to commands very easily, and then all of a sudden, the teacher, the house help, what wanasema mtoto hasikiangi. Most children with hearing loss are labeled to be naughty. And that actually goes on to the point that the child is afraid to speak up about their hearing loss. So instead, before you label that child to be naughty, not to listen, it is quite uncommon for a child not to follow instructions. Go back and have that child checked for hearing, because those are the behavioral cues that help us suspect that our child could be having hearing problem.
Okay, thank you. Does snoring at night indicate anything to do with hearing? Like the child keeps snoring, and has been having flu. Would it have any impact on the ears?
So snoring and flu, they're all connected to recurrent ear infections. So yes, and that is why sometimes when you take your child to the ENT tells you they're going to remove the adenoids. The adenoids are the ones that cause snoring. They are found behind the nose. And the adenoids at the same time cause recurrent infections, which could spread to the ear. So yes, they're interconnected and they should be handled by an ENT.
Okay, thank you for that. We have another question here on managing hyperactivity in children with autism.
Hyperactivity in children with autism could be as a result of one, the autism itself, or it could be a child who has autism and has ADHD on top of the autism. And so step one should always be, let that child be evaluated by a neurodevelopmental pediatrician so that they are able to categorize that child appropriately. Again, according to the level of hyperactivity, there are children who respond to behavioral measures. There are children who must be given medications that calm them down or calm their nervous system down so that they are able to now be taught or to cope or to be calm enough to be manageable. And so I would always encourage such parents to start with a neurodevelopmental physician for appropriate treatment for the hyperactivity.
Okay, thank you for that. I think also comment on that, on managing hyperactivity, could also check on the child's diet. Maybe if the child is doing a lot of sugars, try eliminate and see how that works. And replace. We are normally told to eliminate, but then also there is replacement with something that can still give them energy and not a lot of hyperactivity. You could also try like protein-rich foods. Now this is as a caregiver what we have seen working, and as well as complex carbohydrates. I also welcome other inputs from the rest of us on how to manage hyperactivity in children with autism. And there's also the exercises, like jumping on the trampoline, running around. It can help dispense some of the excess energies that present with our children. So any other question? One of us can ask a question, you can unmute.
I am seeing a question here. There's a parent who is saying there's someone who posted a question that they are managing a child who is a challenge because he keeps chewing on their hearing aids and removing them. And they want to stop this behavior since the hearing aids are expensive to purchase and the parents. Now, this is quite a common challenge because that could be that child's particular obsession. He likes chewing on things, that is the repetitive behavior, and he has picked the hearing aids for any particular reason. And this is where now we talked about a combined or multidisciplinary approach. We have what we call cognitive behavioral therapy. The cognitive behavioral therapy is where you teach that child or you condition that child's brain to behave in a certain way that you want them to behave, especially when you want them to stop behaviors that are not beneficial to them or behaviors that are perceived to be harmful to them. This can be done by collaboration between an occupational therapist and a psychologist, so that the both or even other team members, including a pediatrician, so that we are able to identify strategies to distract this child and to help this child adapt and integrate and find a way to integrate and get other mechanisms or other behavioral mechanisms that not necessarily entail chewing the hearing aids. Sometimes it could be even what we do at home subconsciously as parents. Each time they touch their hearing aids and they chew, you beat them. Within 3-4 times, then they realize, I'm not going to touch, because they associate touching the hearing aids with pain that they perceive after they are beaten. However, this has to be done in a loving way. I'm not encouraging us to go and beat our children. I was just giving an example to engage a psychologist, or depending on the age of the child, or an occupational therapist, so that you can be able to help this child adapt a more healthy behavior other than removing their hearing aids. Sometimes it could be a sign also that the hearing aid is not fitting well. Maybe it's pressing him. Again, going back to the audiologist, because we have other ways of amplification that do not necessarily have to be the way that hearing aid is. There are other options that could be more comfortable, and maybe that child can tolerate such hearing aids better. So it's not a one kind of thing. You can maybe start with the audiologist and slowly look at what you can do to improve that child's living.
Okay, thank you for that. I was just looking at the expectations. One of them, as I wait for more questions, I can see there is a comment. One of the expectations was whether there's a speech therapist, a school in Mombasa. If there's any of us who may know, I know we can get in touch with you later after the webinar, and we can direct you. But just to answer you here and now, if there's any of us who has a direct reply, please feel free to put it on the chats, and then we will get back to you on that or after the webinar through email. Okay. Any other question? As we wait for any other question, Dr. mentioned under physiology of hearing about the calming effect of music. We'd like to encourage you to visit our YouTube page. you will find a webinar on music therapy for children with autism, and you will learn much more, even to the advantages that it has to our children. So we are about to close. Any other question? You can unmute. Okay. I think, thank you, Alex. Is there someone asking? Okay, Rachel, is it a question? Okay, so I want to thank you, Daktari. And before we wrap up, is there any research, any new research that's coming up in the area of hearing, that our children may benefit from? Any current thing happening?
Yes, most of the common, one of the current research is first in trying to identify the problem. Because when you identify the problem, then you're able to see whether you can get an answer. And there's a lot of mist, let me call it mist or mystery towards autism and what causes the language deficiencies in autism, especially because of how much of a spectrum it is. They narrowed down to genetic, and there are like 1,000,001 genes that are connected. So it keeps being a rabbit hole for everyone. However, one of the best discoveries is that the fact that all children who have autism have a problem in decoding language. And so now what is being looked at is interventions, including the cochlear implants or any of these electrical stimuli and different ways in which the children with autism can be helped. But there's still a lot that is still under discovery and a lot that is still under a lot of trials in terms of even the medication and the intervention strategies, especially in helping this coding issue that they have. The brain is very complex in the sense that it is a big Pandora's box that people are not, most of the scientists are still trying to discover. But what has been found, or what is encouraging, is the fact that the brain is also very neuroplastic. Neuroplastic to mean that it can bend, it can adjust, it can adapt. You can easily, if you have an area that is deficit, then you can easily train the surrounding areas of the brain to adapt or to take up the work that is being done by that particular part of the brain. And this brings the importance of early diagnosis. If you have early diagnosis, the children who are diagnosed with autism earlier, they're investigated for these deficits earlier, it is caught and they are taught when they are still young, because neuroplasticity is maximum in the first 5 to 7 years of life. And that helps them have better outcomes in terms of even language and social development. And it helps them to develop better coping mechanisms. So that is all I can say. If there's anything, perhaps next time in the next webinar, we can see whether there will be future developments, especially with technology. I think very soon we are going to see things coming up that are helpful to the children.
Okay, thank you. Thank you so much, Daktari. There is one last question that has come in. My child was diagnosed with autism at 3 years, but I was skeptical about it since then. I have been doing my research, taking her for CT and MRI. We found severe adenoids and delayed melanation or something like that. What does this delayed melanation mean?
Well, that's quite difficult because perhaps it is delayed milestones. delayed milestones. Milestones are the different, and I could be wrong because I don't know what else it is. If it is delayed myelination is when the nerves in the brain are coated or they are covered by a specific substance. And I think that is a bit complex, and it's something that should be handled by a neurologist. And sometimes in some children, it can happen. Again, we say the brain of the child takes time to grow, and it grows for up to 7, up to even 12 years. The brain is still growing and developing. So some of these things, we don't take them. We take them with a pinch of salt, and we concentrate on the child. Adenoids are to do with the back of the nose. If it is delayed milestones, then the milestones are the social, physical, and neurological things that we are expected to achieve as we grow. So by the time the child is 9 months, they should be able to say mama, they should be able to crawl, they should be able to sit without support, they should be able to stand. By the time they are 2 years, they should have a vocabulary of 3 sentences. Those are the milestones. So for this particular parent, it's quite difficult for me to answer them because I don't know exactly what we are dealing with. I would encourage them to seek a second opinion of either a neurodevelopmental pediatrician or even an ENT surgeon, a specialist who will be able to point them in the right direction.
Okay. Thank you. Thank you for that. I hope it has answered our caregiver. So, Daktari, I think that was the last question, and I'd like to give you an opportunity to give a parting shot.
Okay. I think my parting shot is always remember that there is no tailor-made in pack of instructions for a particular person. So all of us are unique. All of us have a unique purpose in life. All of us have a unique life course that is set out ahead of us by, of course, by God. And so what I would like to encourage us is to treat our children in that way. Each child is unique. So don't compare your children amongst each other. Don't compare your children with the other children you have at home. Look at your child. Look at what you can do to improve their lives. Look at what you think is different about them. Seek help, because again, we are not islands. Seek the help of practitioners, seek the help of people who have gone through the same problem, and then find out what works best for your children or what works best for your child, so that you can make for them a package that is unique for their particular needs. And that way you will find that your life will be much, much easier as a parent of a child who is neurodiverse. Yeah.
Thank you.
And I would encourage all of us to adopt play therapy. Play therapy is, or therapeutic play is playing with our children. Play with your children as you teach them. Teach them language in form of play. Play at home, play on the road, play in the car. Look for various ways to stimulate and teach your child through play, because children learn and adapt to their environment through play. So become a playful parent or a playful adult when you're dealing with neurodiverse children, and they will respond to it. It's the most natural thing for them.
Thank you for that. We are told there's a child in every one of us, so we should awaken the child and play with our children. Asante. There is Mary who's joined in, and she's saying, I have a very burning question. So, Dr. I don't know, would you want to take it?
Yes, please.
Okay, Mary, kindly unmute and ask your question. And this will be our last question. The rest we will do through email.
Okay, hi everyone.
Hi.
Oh, my burning question is, I have a child who is 7 years old, who is actually 9 years. He's turning 9 years old in October. He was diagnosed with severe hearing loss, but then we discovered a bit late because we were a bit also in denial. So he was implanted with cochlear implant at the age of 7, but he still has no speech until now. We do therapies twice a week. For OT, we are only working on occupational therapy because he's a bit hyper, and we are still working on the hyperactiveness, not yet the speech. We don't do much of speech because he couldn't concentrate in speech therapies. So my question is to Daktari, what would you advise me? Are there any hopes, or I should just give up on him, or on expecting him to ever speak? I don't know. Because the elasticity, yes, I know the elasticity of the brain. Actually, it's like it ends at the age of 7, yes. But are there any hopes that he will still speak now that he started hearing? His hearing journey started at 7. Are there any hopes of him ever speaking?
Okay, so for that particular child, what I would say is, first one, what I always tell all my patients is that diseases do not read books. And so in as much as books say that neuroplasticity or language development ends at 7 years, it can go to 12 years, it can go to 10 years. What matters is the environment and the determination of the people around that child and the goals that you want to achieve. So when you give a child who is older a cochlear implant, one of the things is that it is going to be a bit more difficult for this child to adapt compared to a very young child, because they had a very long period where even their brain had never perceived sound. And so their brain might take a little bit longer to adapt. And so it's a bit tougher, or it's a little bit of hard work to get this child into therapy so that they can be able to talk. However, even helping this child appreciate environmental sounds that could mean danger, sounds that could mean happiness, sounds of birds, sounds of a dog barking, that is more than enough of a gift as compared to having a child that is totally shut down from the environment. On top of that, there are different ways that we teach these children. And as I said earlier, is that for you to develop language, you need to be able to pay attention. You need to be able to make eye contact. You need to be able to have a good memory. And so if your child is still hyperactive and they're doing OT, OT is good because OT helps them to have sensory integration so that they can be able to sit down and concentrate. You perhaps need to even take a few steps back and go to that neurodevelopmental physician so that they're able to see if this child is not able to calm down through the therapy. Perhaps, as I have learned today, perhaps it's the diet. So let's change the diet. Then again, if the diet is changing, the therapy is continuing, and we are still not able to calm the child down to be able to go through speech therapy, perhaps the child needs to be given medication to calm them down a little bit so that they can be able to sit through and learn language. And sometimes it's even the mode of therapy. Change it, engage everywhere, play with the child. It is so diverse. It could be a little bit of everything. But so for me, I would like to encourage you not to give up, because a mother should never give up on their children. Don't give up, just keep trying. And when something is not working, just take a few steps back and try and find out, what are we missing? What aren't we doing? And look for answers so that you can see whether there's something you can do to improve how your child is coping or adapting to the implant.
Thank you for that. I hope, Mary, that has answered you.
Thank you so much. Thank you.
Take heart, keep going.
Thank you.
There's nothing that God cannot do.
Yeah, true. Thank you so much.
You're most welcome. Now, Daktari, one of our caregiver, Evelyn, who had asked the question on myelination, forgive my spelling, pronunciation. She's really asking me if she can ask you directly the question to get clarity. Please pardon us for this one. Yeah,
It's
Evelyn.
okay, no problem. Yeah.
Thank you. Evelyn, kindly unmute. Just ask it directly.
Okay, thank you so much for the opportunity. So, Dr. I was asking, my baby, for me to take her for to know whether there is anything autism or something. We had noted a bit of hyperactivity and speech delay. Those are the two things that we were dealing with. But when we went we asked for a development or the pediatrician for development sijui what. So they told us she just diagnosed autism. And as a parent, I felt, no, I feel this is something else that we're missing. This is not autism. So I've been going by myself without any doctor's prescription. I asked for something for MRI and CT to just understand about her hearing. And I wanted to study the temporal bone of her ears. So after that, we found from the CT scan, we saw the ears are okay. The morphology of the ear is okay. But there is the delayed myelination about the nerves, and there is the severe adenoids, which were actually making her hyperactive, which after removal, myself, I can see the baby can sleep well throughout the night, not waking up. The hyperactiveness has actually gone down because it is now 2 weeks after the removal of the adenoids, and sleep is okay. No snoring, maybe partially a bit. But there is something I want to know about the delayed myelination before I involve a pediatrician who's a neuro. She deals with the neurologist pediatrician, which I have booked an appointment, but I need to have an insight on maybe what I'm dealing with, because I feel I need to dig more to understand if it is autism or even rule out autism and come to something else. Before that, I need to understand about the delayed myelination, because whoever gave me the result told me this could be the result of speech delay, because that is what I'm dealing with right now. Hello?
So when you talk about delayed myelination, and it's quite brave of you to take up the journey on your own. But sometimes when we take up the journey on our own, especially when we do not have a lot of, or when we don't have information, we find ourselves putting ourselves in a rabbit hole that creates more anxiety and more confusion. And also sometimes you might go seeking for answers in places where the answers that are provided to you are not sufficient. And that just makes it worse for you as a parent, and it makes it worse for you because the brain has a way of taking up things without a filter to know whether they are the right things or they are the wrong things. And those things can be so much in us that they influence how we react, especially towards the people that we love, because we react as a response of love and protection, especially as mothers. So I would encourage you work with this journey with a specialist, somebody who is experienced and somebody who would be able to guide you and answer you very well. The second thing is when you talk about delayed myelination. Myelination is a process which the nerves continue developing and developing to the point that they have a particular way that they are coated. And children, when they are born, all the children have the myelination of the brain that even as we see on MRI, we always have to correlate it with the clinical presentation of the child, because it is a process that, it is variable, and it is a process that can take time. So having a diagnosis on an MRI scan may not necessarily mean that your child has a problem, because this would be something that we are seeing at a particular stage of development. So it is very important to even have that MRI looked at by somebody who, it is also very objective. If you did an MRI in a place where they don't see a lot of children's MRIs, it is not common for children to have such tests. Then they could be talking from a point of knowledge where they are comparing with the adult ones they see. And children, they are still growing. And so maybe it is a report that is not 100% reliable, bringing in the point of bias. So it is important you have it reported also and looked at by that pediatrician who has probably seen 100 MRIs in 100 children and will tell you for her age, this is a normal finding or an abnormal finding. So that is an answer that even I cannot give you because I have not seen the MRI. I am not seeing the MRI as it is. However, to encourage you is that even if that is the problem, the issues that are to do with autism, autism is a problem where you have disordered or not well synchronized activity in the brain, which means information in the brain is not relayed very well. As I explained, you have to perceive and then the brain has to process. And for it to process, the nerves look like cables. And in order for the cables not to mix up the information, then each cable has its own cover. You see how electricity cables are. That is exactly how our nerves in the brain are. So when we say there is a problem with demyelination, then there's a problem with the covering of those nerves. So maybe they keep sharing or leaking information and short-circuiting each other, which again is something for a specialist to discuss, not even for me to discuss, because different issues have different answers. So Evelyn, I would first commend your love for your child and your devotion in finding an answer for your child, but I would also like to encourage you to seek guidance from the appropriate healthcare practitioner so that you can get the right answers for your child. And sometimes accepting is also the first step, because we also say in medicine, if it looks like a duck, it is walking like a duck, then it is probably a duck. So you need to see that child. She's not an abnormal child. She is just a diverse child. She's neurodiverse. She's special. But if you accept, then it is easier for you to even walk through the journey of treatment and not waste a lot of time for the child.
Okay. Thank you.
Thank you, Dr. for that. I see it's already past midday. I'd like to encourage all of us, please visit our YouTube page, even in the journey of acceptance and just working with fellow caregivers. Plug into our past webinars. You will really feel you're not alone, and it will help you in the journey, because we are quite a number there just sharing our lives. So Dr. thank you so much. We are so grateful and so humbled to have you here. I've seen some of the comments. It's been very informative. Indeed, it has. We can only say thank you and God bless you. I would also like, okay, sorry.
Thank you so much, and God bless you too. It was a pleasure having to educate you.
Thank you.
Thank you. Yes.
I would also like to thank all of our participants. You've created the time. You could have been anywhere, but just being here, we are very grateful for your presence. Together, this has happened because you came, Dr. came, we've all been here. And so even to all of you, a good, we want to wish you a good day, and God bless you as well. So we come to the end of our webinar. And as we normally do it, we close with a word of prayer. We'd like to invite one of us who's our mother. We call her our mother, Gifted James, to please close this for us with a word of prayer. So Mama Ruth, please unmute yourself and close for us with a word of prayer.
Okay. Thank you very much. Let us pray. Our Heavenly Father, the Father of our Lord Jesus, we are so grateful this day that you have allowed us to be alive and even, Lord, to be in this webinar, O King of Glory, to learn to be caregivers that brings glory and honor to God. We thank you for Dr. Lillian today, that we have learned so much about hearing aspect. We want to pray, oh God, in whichever sphere we are in, God of glory, you will give us grace, you will give us unconditional love, and you will give us strength to continue with this journey, to move forward. Thank you because we are fearfully and wonderfully made. God of glory, help us to love what you've put in our hands, and that, Lord, our purpose will be significant even as we live day to day. We bless your holy name. God of glory, remember the children, the parents, O King of glory, the relatives, the friends who come in as caregivers. Lord of glory, give each one their part, and even together we join as a team, and we will see the success of what you have put in our hands. We bless your holy name. And now may the grace of our Lord Jesus Christ and the love of God and the fellowship of the Holy Spirit be with us now and forevermore.
Amen. Amen.
God bless
Thank you. Thank you.
Thank you so much, Mama. We appreciate.
Mm.
So to all of us, have a blessed afternoon and the remainder of the day. We will share this on our YouTube page and on our socials. You will find it once we upload it. God bless and goodbye.
Thank you. Thank you so much.
Goodbye. Thank you so much.
Thank you.
Karibu.